So guys, so we're going to do like mock today. Um, I'm going like to time Dr. Hamid for at least 6 stations as per the exam. So we're going to time him for 9 minutes for each station, okay? And yeah, so after that, after we finish the mock, I'll give the feedback after that, okay? But it's going to be non-stop actually. So um, shall we start, Dr. Hamid? Can you hear me, Dr. Hamid?
Yeah. Just you can start.
Okay, so let me share the screen for the first station. So you're going to have 1 minute for the scenario and then 9 minutes inside the station.
Okay.
As per the exam regulation. Can you see the screen? So your 1 minute start now. So this is going to be question and answers. So questions and answers. So it's knowledge station, okay?
Okay.
Yeah. So into the station now.
Hello.
Yeah,
This is
good
my candidate
afternoon.
number.
Yeah,
Good
thank you.
afternoon. This is my candidate
Yeah,
number.
thank you. So you can take a seat, please.
Thank
So
you.
if you have you read and understood the scenario?
Yeah.
Okay, so what are your differential diagnoses?
Patient can be having pulmonary embolism, or he can be having atelectasis, or he can be having pneumonia, or he can be muscular pain in the chest.
Okay, so what is the scoring system for pulmonary embolism? Do you know?
So, may I get this question after?
Okay, all right, that's fine. So what are the risk factors for pulmonary embolism?
Obesity, recent surgery, and patient bedridden patients, and most of the trauma and DVT, hypercoagulability. These are the common risk factors.
Okay, so what investigation would you like to request for this patient?
So along with the blood investigations, acid APG analysis, the specific investigation which is required is the chest X-ray to know about the. Then along with this, the special investigation will be CTPA.
Okay, so which is the gold standard investigation?
CTPA.
Okay, all right. So what's the pathogenesis of DVT?
So it's basically the virtuous stride,
Yeah.
hypercoagulability.
Okay.
There is a low flow, restricted flow, and there is the third part is the tride, involving the three things. First is hypercoagulability, viscosity is increased,
Yeah.
and then
What is the third one?
obstruction to the flow, and third one is maybe dehydration or something like that.
Mm-hmm.
Or most of the time malignancies or stasis.
Okay. So how to prevent DVT in surgical patients? So the prophylaxis of DVT in surgical patients.
So it can be a pre-operative, intraoperative, and post-operative.
Mm-hmm.
Pre-operative, you have to just take care of the patient's coagulation profile. You have to look after that and maintain the INR and the prothrombin time, all the levels. Then you can check the hemoglobin and platelet counts. And then you can, during intraoperative, you can advise for the TED stockings or pneumatic compression devices can be used.
Mm-hmm.
Then maintain the blood, means you have to just take care of, prevent the, no blood loss should not be there more during surgery. And then post-operative patient needs early mobilization, removal of the drains and walking and all that, or some types of, even it can be continued with the pneumatic devices, calf compression devices. So these are the common things which can prevent, and regular exercise and all that can be the common thing post-operative also.
Okay, all right. So, what is the management of pulmonary embolism?
It depends upon the intensity. If it is a saddle embolus or a small embolus, if it is a big embolus and causing severe respiratory distress, that needs uh, this thoracotomy and removal of the embolus through the open surgery. And if it is a small embolus, that can be treated with the catheter-directed thrombolysis, or if it is just a tiny embolus, low molecular weight heparin, and these drugs, medical drugs, can be used to for the treatment of DVT, the pulmonary embolism.
Okay, so you mentioned low molecular weight heparin. So, what the mechanism of action of heparin?
Basically, heparin prevents the intrinsic mechanism of coagulation, so that prevents formation or activation of factor 10, and it prevents excessive coagulation. So that is the basic in embolism or hypocoagulable DIC, descended intravascular coagulation. The mechanism is excessive coagulation. So that is the heparin prevents it.
Okay, so what the antidote of heparin therapy?
Protamine sulfate
Okay, so
is a drug.
how to monitor heparin therapy?
So it should be monitored by measuring the APTT and coagulation profile.
Okay, all right. So, so in the case of long term, what the long term management in case of pulmonary management?
It depends upon you. The patient is having recurrent pulmonary embolisms, so the preventive vena cava filters can be used, and the patient, such patients needs lifelong warfarin to
Okay,
prevent in
so
the future.
all right. So how long we are going to give warfarin for how long?
So in a minimum at least 2 years, 2 to 5 years.
Okay,
Some
so
patients need lifelong also.
all right. So what the mechanism of action of heparin? Yeah, warfarin.
Warfarin, it acts on the factors 2, 7, 9, 10. So it
3 minutes
prevents,
remaining.
so vitamin K dependent factors, they are inhibited because of warfarin. So that prevents the coagulation by extrinsic pathway most of the time.
And how to monitor warfarin?
Warfarin, it can be monitored by prothrombin time and the bleeding time, PT and VT.
Okay,
INR is also important. It has to be within 1 to 2. It should be normalized, internalized. Normalized ratio has to be between 1 to 2.
all right. So thank you. That's the end of the question. So do you want to go back to the question you skipped?
Yes, that criteria is something,
Yeah. So
criteria for
the
pulmonary embolism. It's Rome or something. I'm just missing that name.
yeah. So the
So
scoring system.
scoring system. So it depends upon the, so many factors are there. Each factor has got one score. So that is about the age and obesity and
So
previous.
what's called the scoring system? What the name of the system?
Sorry, I'm not remembering this name of the scoring system.
Okay. So what does it include? Yeah. So carry on with your answer.
It includes the previous history of DVT or embolism, or a patient is having major surgery or lower limb surgeries, for more than 3 hours and all that. And obese patients, old age patients. So all these factors are calculated and the weightage is given. If it is more than 5 something, the patient is having high risk for getting pulmonary embolism. And less than 2 to 5, it is moderate, and less than 2 is no risk.
Okay, all right. So thank you. That's the end of the questions. You can wait until the bell ring. So you have 40 seconds before the end of this station, but we're not going to wait that long. We're going to go to the next station. So let me share the scenario for the next station. So into the station.
This is the candidate number.
Yeah, thank you. So you can proceed with the question.
Hello. Myself, Dr. Hamid, one of the surgical doctors here. May I know your name and age, please?
John Smith, 60. I don't remember the same. So 60, yeah. John Smith, 60.
Okay, Smith. Will you please sit on this? Okay. May I call you Smith?
Yes, that's fine.
So, Smith, I will be just examining you about your tummy, your eyes, and the body. And is it any problem with you? Are you having difficulty of pain or something at present?
Yeah, so like you have little bit of pain in the left side of the abdomen.
Okay. Is it bearable? Sure. Do you need any
Yeah, yeah, yeah.
painkillers?
Yeah, it's okay.
Okay. Thank you. So, can you show me your hands? Fine. Show me like this. Okay, fine. Can you please look down? Yes. So can you make your hands like this? Straight. Okay. Will you please sit down? Just stand here. I'd like to take out your gown. Is it okay for you?
Yeah, that's fine.
Thank you. So will you please lie down here? So I'll be just exposing your tummy. Is it okay?
Yeah, that's fine. So assume it's exposed because the patient is going to be wearing just gown, most
Okay.
likely.
Yes. So Smith, I will be just looking at your tummy. Take a deep respiration inside. Okay. So Mr. Smith, I will be just pressing your tummy. If you get a pain, let me know it.
Okay.
Are you getting pain?
Yes, here, right here. So there's pain.
Okay, sorry. So I will be little pressing little bit hard.
Yes, there's pain here.
Okay, sorry. So I will be just tapping your tummy. It's okay, thank you. I will be just tapping on this side. Will you please turn on this side?
Okay.
Okay, fine. I'll be just putting like this, no problem. So let me listen the sounds from your tummy. Take this. So can you please sit down? Just let me listen the sounds on your chest. Take deep breathing. Just straight me. Let me see here. Okay. Can you please make your legs start, please? Let me see. Are you getting pain on the legs?
No, not at all.
So you can put this gown up.
Okay.
It's okay.
Okay. So, would you like to give me summary,
Yeah.
please?
I just
Okay.
examined Mr. Smith, 50 years old man. He is having complaining of abdominal pain and itching all over with yellowish discoloration of the eyes. On examination, he has no signs of liver failure on the general liver failure, signs like yellowish of the nails or everything. And there is no pallor. On abdominal examination, inspection, there is normal, there is no any lump on inspection. Even there is no tenderness, little bit tenderness on the left uh, hypochondrium as well as left side of the umbilical area, and there is no palpable mass, there is no ascites. So after this complete
Okay.
examination, I would
So
like,
3 minutes. 3 minutes remaining. So yeah, what would you like to do? Yeah, carry on.
so I have to like to do complete examination. There's no suprathecal lymphadenopathy, rectal examination, and do the investigation. Probable diagnosis is maybe CA
So
malignancy of.
yeah, what the most common cause of Bell's jaundice?
So it's malignancy of the pancreas, head of the pancreas, leading to obstructive jaundice.
Okay. So what's Corvus law?
Corvus's law states that whenever the gallbladder is palpable, it is non-malignant. If it is jaundice is there and gallbladder is not palpable, it is most of the time obstructive type of jaundice.
Okay. So what the presentation of patient with obstructive jaundice?
And the patient has yellowish discoloration of the sclera and itching all over the body because that skin is irritated, that deposition of bilirubin that causes irritation, itching, and even the patient has yellow urine as well as stools, pale stools, and the stools cannot be flushed.
Okay. So what the tumor mark of pancreatic carcinoma?
CA 199.
Okay. So what investigation would you like to request?
The patient, along with a full blood count and liver function test, and for evaluation of the pancreatic enzymes, amylase, and all that, and electrolytes, serum calcium, and along with this, CT abdomen to know the exact staging of the malignancy, and CT of the whole body to know about the secondaries in the lungs and bones. and uh, these are the common investigation.
Okay, so what type of bilirubin is going to be high in case of obstructive jaundice?
It will be a conjugated bilirubin because it is post-hepatic.
Thank you. That's the end of my questions. Now you can go to the next station. Let me share the scenario for the next station. Yeah, so enter the station.
Hello, this is my candidate number.
Yeah, thank you. So you can proceed with your question.
Hello, myself, Dr. Hamid, one of the surgical doctors here. May I know your name and age, please?
Yes, you can speak if you want. So
You
Emma,
can speak.
Emma Smith, then. Yeah.
Okay. Okay, Emma. Today I'm going to check your, examine your nerves from the brain, which has affected you eyes as well as taste. Is it okay for you? Are you having problem with the vision? Can we see it? Okay.
Yes, I do have double vision. Yeah.
So you are having, okay. So Emma, just you can close this one eye on this side with this hand and just look at my finger. Now close the other eye. Now you can open both the eyes and just look at this. So how many fingers are you saying now? Okay. So I will be just putting this salt on the tip of your tongue. If you please tell me, can you have the sensation? Can you show me tongue?
So there's lots of
Yes.
sensation.
Okay. So can you please raise your eyebrows like this? Can you close the eyes slightly? I will just try to pull it out. Can you make your like this? Can you show your teeth? Can you stretch these muscles? Okay. I'll be just touching and seeing this here on both sides. Are you having pain or here somewhere?
No.
Okay. So That's okay. I will be just consulting with my consultant and come meet you. Okay, thank
So
you.
anything else would like to do, doctor? Still have time.
So I can check this. If the other nerves are involved, I can check
Yeah,
at
so
the 9th,
this
10th.
patient, so you remember the scenario of this patient, right?
So patient is having diplopia
Yeah,
and loss of taste sensation.
yeah. Okay, so
So,
anything else you would like to do? Finish your examination.
so I'll just go for the cerebellar examination for the rhomboids as well as because if the
No,
cerebrocolpine
I
angle.
mean in the cranial nerves examination. So
So eight, I will just ask the patient to make the say A and C for the uvula, tongue as well as shoulder or other nerves also.
um, so just let's go back to basics, doctor. So patient, so which cranial nerves relating to this problem? So the problem the patient is having now. So like.
Even even the vestibulocochlear nerve for that the Raynaud's and Weber's test has to be done.
Mhm.
So
Okay.
diplopia can be that
Before that, which test you would like to perform?
the vision, the optic
Yeah.
vision.
Uh-huh. Yeah. So what would you like
So
to
if
do?
the we have to see for the chart from the 6 feet distance to look for the
Okay. So if there's
and
no chart available inside the station.
so I'll be just doing this pupillary test and asking the patient to look the she has already seen she is able to see that vision optic nerve is okay she can see identify it.
So no, that there are other tests you can do in the optic nerve. So what are the other tests?
The color vision, if the Snellen's chart is there for the Ishihara chart, if it is there, I will just ask to
Yeah.
that.
So this patient is having like impaired color vision. So this is one of the findings of this patient.
Okay, that Ishihara chart has to be done, shown, and that patient should identify
Uh-huh.
the numbers.
Okay. All right. Yeah. So this patient, and there's something else. So I'll give you the findings of this patient. So we have impaired color vision and by temporal hemianopia and ptosis. Okay, and loss of sensation in the anterior 2/3 of the tongue. Okay. So these are the positive findings in this patient. Um, so 3 minutes remaining. So I'm going to ask you some questions now. So which cranial nerves run through cavernous sinus?
Uh, Oculomotor, trochlear, and ophthalmic division of mandibular nerve.
Okay.
Mandibular nerve. There's adjacent nerve.
Okay. So what are the features of oculomotor palsy?
So that will lead to ptosis as well as
Mhm.
the loss of the pupillary dilatation will be there. Unopposed
Okay.
parasympathetic stimulation
Okay.
will lead to dilation.
All right. So, which nerve supply taste in the anterior 2/3 of the tongue?
Chorda tympani, a branch of seventh facial nerve.
Okay. So, in case of cavernous sinus thrombosis, what are the red flags?
Uh, Third nerve palsy or uh, abducent nerve may is passing through it. That can be sixth nerve palsy can also be seen. These are the red flag signs because and defect in movement of the eyeballs because of nerves passing through it.
Uh-huh.
Then the patient is having visual difficulties, diplopia, strabismus. All these are the.
Okay. Anything else?
May I have this question afterward?
Okay. So, what investigation would you like to request for this patient?
CT scan brain and all the along with the blood investigation and all that, CT scan brain will be the basic.
Mm-hmm. Anything else?
Fundoscopy, then uh, uh, nerve studies is
Okay. Yeah. So
and
thank you. That's the end of my questions. Um, would you like to go back to the red flags of the?
awareness sinus thrombosis.
Yes.
Sorry, I'm not getting that answer.
Okay, no problem. So just you can wait until the bell ring. So I still have 15 seconds. Okay. So in that case, we are going to go to the next station. Yeah. So this is your next station. Okay. So enter the station.
This is my candidate number. Good
Yeah. Good
afternoon.
afternoon. Yeah. So you can proceed with the patient.
Hello, myself, Dr. Hamid, one of the surgical doctors here. May I know your name and age, please?
Yeah. My name is
Okay,
Adil
Miss.
Amfoti.
Okay, Adil. So today I will be just examining your hand up to the fingers as well as arm up to the shoulder. And are you having pain, any difficulty at present?
No.
Okay. Adil, can you please make your hand like this? Let me check it. Can you make
Okay.
your hands? Can you show me like? Okay. So just keep the hands like this. Let me see the thing. So, Mr. Adil, just can you make your fingers, keep the fingers like this? Can you bend it like this and press against my hand? Press it. Okay. Can you just open it? Open it against my pressure. Okay. So, can you make your thumb like this against my pressure? Okay. You try to press, open it, fingers, open it.
So
Okay.
there's weakness in the fingers abduction. Yeah. There's weakness.
So can you please hold this in between your fingers like this? On this side, on this side. Okay. So just try to hold this tip up in with this
Yeah.
and
So
just try to pull
the
it.
thumb on the right side is flattened.
Okay. Okay. Thank you. So I'll be just touching it with this cotton. You please tell me yes if you are feeling the sensation.
Yes. 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 Yes.
On the back of side, on this side, just tell me, are you feeling sensation?
Yes. Yes. Yes.
Thank you. So, are you having pain on this side? Let me tap here. Are you getting
Yes,
any
sir. Tingling, yeah. There's tingling.
tingling? So, thank you, Adil. I will just consult with my consultant and come meet you with this.
Okay, so any other tests you would like to do?
Uh, the tunnel sign and all that for the median. This the test which I would like to do because but can you make it like this? Press it like this. Are you getting tingling? Okay.
No.
Yes, I will tap here. Are you getting feeling tingling?
No.
That's all.
Okay, so if you're happy with the examination, you can present if you're happy to present.
I'm examining the Mr. Adil, a 40 years old man. He's having weakness, came with the complaint of weakness in the right hand. On examination, he has got uh, uh, muscle weakness in the fingers, and the Fromet sign is positive, and there is tingling sensation and when tapping on the medial side. Most probably, he is suffering from ulnar nerve palsy on the right hand.
Okay, so what could be the cause of ulnar nerve neuropathy?
So most commonly,
Ulnar nerve palsy.
it can be because of any injury on the medial epicondyle, or it can be because of compression of the ulnar nerve in the Gans canal. It can be because of diabetic neuropathy. So
Okay,
these are the possible.
all right. Anything else?
So any fractures, unnoticed fractures, or any
Like
excessive use of
which vitamin deficiency can lead to?
vitamin B12 deficiency can also lead to neuropathy.
Okay, so which area is supplied by ulnar nerve in the hand? Which part of the hand supplied by ulnar nerve?
The sensory supply is 1.5 fingers on the palmar as well as dorsal aspect of the hand.
Okay, and the median nerve?
Lateral 3.5 fingers on the palmar side.
Okay, so what investigation would you like to request for this patient?
So basically nerve muscle studies for the uh, as well as MRI of the joints if the compression is there, and electromyography that is for the muscle, either it is muscular or neurogenic cause. Then along with the lab blood investigations for deficiencies of vitamins and all that, diabetes, blood sugar level and all that.
Okay, all right. So this end of the questions. Now you can wait until the bell rings. Okay. Um, but we are not going to wait actually. So we are going to go to the next station.
Okay.
Okay, so now into the station.
Hello.
Yeah,
Yeah,
hello. Yeah.
this is my candidate number.
Okay, all right. So, thank you. Can you show? Can you see this X-ray? What's the finding in this X-ray?
The X-ray is showing totally decrease. It can be a pneumothorax on the right side.
Okay, all right. Thank you. So, can you define pneumothorax and its clinical side?
Pneumothorax is the decrease. This is the trapping of the air into the pleural cavity on the right, in between the visceral and the parietal peritoneum, with collapse of the lungs. And the clinical signs is patient is having severe pain, difficulty in breathing, and deviation of the trachea on the opposite side. Even mediastinum can shift on the opposite side. On percussion and palpation, you get dull sounds, resonant sound on the right side.
Okay, so what could be the cause of pneumothorax?
It can be traumatic, or it can be iatrogenic when a patient is having most of the time in the ICU, in the ventilators, rupture of the gully that can lead to, or it can be while insertion of the central cannulation of the interjugular vein or something.
All right,
It
yeah,
can
that's
happen
fine.
in
So, yeah, how do you proceed with this patient?
the patient. It depends upon if it is a tension pneumothorax emergency, you have to put a needle thoracostomy in the fifth intercostal space on the mid-axillary line or anterior-axillary line, and
Mhm.
then put a chest drain on after the tension pneumothorax is released.
All right. So,
28.
what are the indications of chest drain insertion?
So it should be inserted in an emergency, just like a pneumothorax, or it can be inserted for any traumatic hemothorax, or it should be inserted in the pleural effusions because of malignancy, tuberculosis, or some sort of disease which needs the fluid and air to be drained out under the underwater sea.
Yeah, so you mentioned, yeah, what else? Any other indications?
Even in post-thoracotomy, the drain is put inside the chest.
Yes. Okay, all right. So there's a mannequin inside the station. Can you talk me through the procedure of insertion of chest drain, please?
Okay. Okay. So I'm just inserting. May I know your name and
No,
age,
there's
please?
no patient. There's just a mannequin. So just talk through with the examiner through the procedure.
Okay. So the patient is having this person is taken in the position of 30 degrees or 45-degree head up position,
Mm-hmm.
and the hands is put on the upper side, and just I will palpate the. First of all, I will just confirm
Mm-hmm.
the patient which side is involved. If it is on the right side, and see the WHO checklist and keep all the instrumentations, everything. I will just take it ready. If I got assistant, I will just check the drain.
Yes, you do have an assistant.
This
Yeah.
so will you please check this date of expiry? It
Yeah.
is
So it's not
29.
expired. Not expired.
Okay. So the mannequin is that. So I will be. It is a the measurement of the ribs are done, and on the safe triangle,
Yeah. Show
this
me
is
how
the
you're going
safe.
to how you're going to do it. Yeah. Show me.
So external angle is the second rib. From that, this is second intercostal, third, fourth. So nipple is most of the time on the fourth intercostal space. So below that, this is the fifth intercostal space. So if I go, and this is the fold of the
Yeah.
pectoralis
So carry
major.
on. The patient is draped and anesthetized. Yeah. Carry on with the insertion of the chest drain.
So I will just put the gloves, and I'm two gloves on
Yeah.
the side.
That's fine.
So
Yeah.
I'll just, it is
No, it's
painted and
anesthetized
draped.
already. It's anesthetized already
Okay,
and draped.
it's
So that's
sanitized.
yeah.
So I will just say if the patient is having pneumothorax, this patient will require at least 24 number smaller size drain. and this train will be checked, and here the trolley is made ready like this, and anesthetized. The incision will be taken on this side in the safe triangle.
Mm-hmm.
So, so incision will be just on this side,
Mm-hmm.
around 1 to 1.5 centimeter transverse incision, just at the
Mm-hmm.
border of upper rib. Then I
Okay.
will just uh, take it such deep. Then I will do dissection with this artery forceps, blunt dissection, little bit.
Okay.
Then I will try to put a finger and do finger dissection in a
Yeah. So
direction.
why are you doing
And
finger sweep?
so finger sweep is just to prevent if the lung border is lungs is touching. So that will push the pleura. If suppose accidentally pleura lungs
Mm-hmm.
should not be injured or vessels should not be injured. So that will make a blunt hole, and then I will just see that the drain is there, and if the
So
posterior
the
end of the
drain is
drain
having
is,
trocar. So the chest tube is having trocar.
the trocar has to be immediately removed, and the
Mm-hmm.
posterior end of the drain, if suppose this drain is having open, it has to be clamped on the
Okay. Three
posterior
minutes
side,
remaining.
and then just I will widen the incision and put the drain into inside, just in this manner, inside the
Okay.
chest, in the direction of the opposite shoulder. So it
Mm-hmm.
will be on the direction toward the opposite shoulder,
And how
so
long are you going
that
to insert? How long are you going to insert?
so all the holes of the drain has to be there. At least
Mm-hmm.
all the holes should be inside the chest. So holes should
Okay.
not be out. So
All
once the
right.
drain is put inside, and the person, it is connected to the underwater seal. So this is the underwater seal,
Mm-hmm.
which has got water here at the lower level. It should be, the water should be filled to the level that
Yeah.
the
So
end of the,
assume it's ready. Assume it's ready. The underwater seal is ready. Yeah.
okay,
So what
that's
you are going to
ready.
do next? Yeah.
So it will be connected. Then the drain is, I will see the water column. Column is moving. The air column is
Mm-hmm.
moving. If
Okay.
the bubbles, and then once it is confirmed that the drain air column is moving properly, so drain will be fixed by a suture uh, material surrounding suture. This is fixation of the drain with the suture, and then it will be, when suturing is done, uh, sticking has to be applied so that this should not come out.
Yeah, you can do it. You can secure it. Yeah. So
Okay,
just
just I will secure it.
so which suture you're going to use?
It's one number muscle, basically one
Okay.
number muscle. It's such
Okay.
a manner that hold it. So this is suture surrounding the drain, and these threads are,
Okay. So what are you going to do after that?
so this is fixed to the drain so that drain should not be coming out. Then once the suture is, another suture is taken, horizontal suture, and it is stuck with the, uh,
Yeah. So what's the next step? What's the step after that?
so once this is done, now the thing is that the column has to be checked, and the person is, the chest X-ray has to be done to confirm the
Yes.
drain is in the position.
Yes. Chest X-ray. So time up. Thank you. That's the end of your station. You can go to the next station now.
And
Okay. So this is your next station.
Okay.
Okay, so into the session.
This is my candidate number.
Yeah, good afternoon. So you can proceed with the patient.
So, good afternoon. I am Dr. Hamid, one of the surgical doctors here. May I know your name and age, please?
John Smith, 68.
Smith, can I see your wristband?
Yes, the patient is wearing red wristband.
Okay, are you having allergy to latex and all that? You're
Yes,
allergy to
I'm
which?
having latex allergy. Yeah.
So, okay. So, Smith, I'm just going to ask few things because as you are having difficulty in passing urine, so have you ever got this the same thing before?
No, it's the first time.
Have you ever put the catheter? So
No.
before putting this, starting this, let me check your tummy.
Okay.
So okay. So Smith, as you are having not able to pass the urine, so I will be putting a catheter. That is a tube. This is a hollow tube which has to be passed through your penis. And while doing so, it is under the clean condition. And we will be just putting, I will be putting a numbing agent, and you will not be feeling any pain during that. It will be a little bit uncomfortable for you, but please bear it that it will help to pass the urine which is trapped inside. Is it okay for you?
Yeah, that's fine.
Okay. Thank you, Smith. Just bear with me. I will be just cleaning this little bit, pulling the skin behind.
So the camera is not showing the cleaning.
These are the,
Yeah. So assume just you have only one gauze.
yeah, only one word. Okay. So this is surrounding, I'm cleaning it, surrounding the prepuce. Then anterior to posterior, I'll be cleaning it and disposing it, all this into the waste. I'm just putting all the things. So after cleaning this, I will just passing this jelly inside, just
Mm-hmm.
pushing the jelly inside. You will feel little bit numb here. There will be no pain. And within 1 to 2 minutes, you will be feeling little bit numb on your penile area.
Okay. So the patient
Okay.
is asking you to drink some water.
Okay. So you need a water at present. So I'll
Yeah.
just give the hot water. There is no issue. I'll just change the clothes.
Okay.
So if the assistant is there, I will just check the expiry of this catheter. It's 29, and he has given me this pad. He will put on the sterile area. The upper part is actually removed with this. Just bear with this. I'm just trying to put it slowly. Take the deep breathing inside.
Yeah. So the patient is having a little bit pain now. Yeah.
Yeah. You will be just getting little uncomfortable and pain. Just take a deep breathing. So when I try to push it deep inside, you will be getting little bit pain. So is it okay for you? Should I wait or is it okay?
Yeah. Yeah. You can proceed. You can carry on.
Okay. Oh. So once I put it, so I will be just checking whether the urine is able to flow from this. If it
Yeah.
is flowing,
Yeah. So the urine is coming out. So what you're going to do next?
So it's coming, so it will fine. I'll be inflating this with the 10 ml distilled water inside and just connect it with the urine bag.
Okay.
So are you getting relief now?
Yeah.
Okay, thank you.
Thank you.
I'll just dispose all this in the waste.
Okay. So can you mention 5 types of catheters?
So the catheters, basically, these are the Foley's catheter, maybe three-way or two-way Foley's catheter, or it can be a metallic catheter or cowrie tip catheter. There can be a condom catheter.
Okay. So what are the complications of catheterization?
Uh, so it can pass into the false passage, or it can cause the trauma to the urethra, leading to urethral tear. Or if the bulb is sometimes inflated in between inside the urethra, it can cause rupture of the urethra. And it's for the long standing, if the catheter is kept inside, it can lead to infection. And these are the common complications.
Okay. So what are the contraindications of catheterization?
If the patient is clear cut having a history of trauma and there's blood at the external urethral meatus, and that there is an absolute contraindication, or there is a stricture of the urethra, so that is also a contraindication. And malignancies of the prostate or something causing total obstruction, that patient also cannot be catheterized.
Okay. Thank you. That's the end of the questions. You can wait until the bell ring. And actually, that's the end of the mock. Yeah. Thank you. Well, so there's like the important thing is you are not rushing, you are taking your time and showing confidence. So these are very, very important things in the exam. So these are very important things. Most of the candidate will like be rushing, will be like hesitance, will be so. Yeah, there are some defects, especially in the examination, but still you performed in a very good way, in a confident way, in like a calm way. So that's very important in this exam. Very important. So the exam is about your performance. Okay, it's not just the knowledge. Okay, so you did very good in that part. Um, so in the examination, actually, I think you didn't check the patient jaundice. So you check, no, you check the patient jaundice, but with one finger. Like I don't remember. You did the
Yes.
polar. I think you just did the polar
No,
with
no,
one
no.
finger. So
Upper eyelid. I just asked him and to look it
so
down, so that
yeah,
is
yeah,
just clear up.
yeah. So you are going to do the like for polar, you are going to use two index, and for
Scalar group.
jaundice, yes, like this. Yeah. No, no, for jaundice one hand, and for polar
Okay,
both
got that.
hands. Yeah, yeah. For polar both hands, for jaundice one hand. And you can inspect like ask the patient to open their mouth, lift up their tongue, and these things, and inspect the chest as well. So you skip that part as well. So this part of like stigmat of liver
Liver
disease.
failure.
Yeah, yeah, yeah. So you didn't expect that in your like the first part, but you were taking your time. You were not rushing. You were like communicating in a good way with the patient. So yeah. Um, like the summary. So the summary just mentioning positive findings. If there's important negative, we're going to mention it because you are just mentioning negative, negative, negative. So the professional way is mentioning the positive findings. In this case, which is right iliac fossa, pain and tenderness. So these are just the positive findings. So the important negative, you are going to mention them if there's important negative. So that's the best way of summary. So you started by mentioning that just the negative findings. You can present as you presented. This patient presented with jaundice and like itching, I think. So so what's in the scenario? You can say it. If you want to say it, you can say it. And this is one of the repeated scenarios in the exam actually. In one of the exams, it was normal examination, no findings. And I remember in one of the exams, in my exam, the patient was like the same scenario, having left iliac fossa tenderness. The same patient was having right iliac fossa tenderness and right hypochondrial tenderness for other candidates. So just you have to do your task, and like they love this. So doing palpation sitting down. being at the same level of the patient. So, and you did that in a very confident, good way. So, yeah, well done in that part. So in the cranial nerve examination, you like ask the patient to close one eye, and you did the H shape. So you didn't do it for both eyes. You did just one eye. You did the H shape, and very important. So this patient is presenting with visual problems. So you have to finish the optic nerve examination. So there are many like things in the optic examination. So first you are going to ask the patient to like concentrate on a point behind you, and then like ask them to concentrate on this object, and then you are going to use torch, swing the light between two between the eyes, and then you are going to do the visual equity, visual field, and color vision. So you skipped all of this. So these are very important things. If the patient if they are not present inside the station, the Shahara plate and the Snellen chart, the examiner is going to tell you yeah, but are the very important parts of this examination, because this patient presented with diplopia. So very important to do
So
this.
what was the stem in this? Actually, I saw that stem was having
So
only
the patient
diploma
was
and the
presented with diplopia and
taste
loss of
sensation, loss of
taste
taste.
sensation. Yeah, yeah, yeah,
So bitemporal hemianopia and everything, it was not given anywhere in the stem. So
yeah.
I thought it is
So but in the
about
findings, if you did the the test, I should have told you there's bitemporal hemnopia, there was ptosis, there was like, yeah, but
okay, okay.
you didn't do them. That's why I didn't give you the
So
after you
yeah,
finished the,
actually, I was
yeah.
confused with this whether it is for the cerebellar tumor, means it is seventh and eighth or something like that, because
Mhm.
the same scenario has got the diploma in cerebellum. Whenever there is a cerebellar tumor, something we get a diplopia and
Actually,
loss of taste. Means
actually, to
seventh
be
nerve and
yeah.
eighth.
Yeah, to be honest
This
with
is
you,
confused.
I had this in the prep course with the Royal College, but it was in like one of the popular
Okay,
stations in the exam. So in the exam, we have like
okay.
the three steps, the popular
Mm,
station, three steps, and the fourth one it was
yes,
like the endarterectomy. So, but the popular are
yes, yes.
the three steps. So this one, lot of the popular stations. But again, you are going. So if you have been confused about this scenario, so the main complaint of the patient is the diplopia. So you have to do all the optic tests
Okay,
and
okay,
the sensation, the facial. So the taste sensation. So you have to do all of them. So you have to make sure you did them in and out. But anyway, if they didn't mention which cranial nerve you are going to skip, you are going to do all the cranial nerves, unless the examiner asks you to skip this one. Okay.
okay, okay.
Sometimes, so there are different scenarios in the exam. Sometimes they'll mention which cranial nerves you are going to do. Sometimes you are going to enter the station, and there's going to be fundoscope and otoscope. When you start doing them, before just start like holding them, the examiner will ask you to skip this part. So there are many scenarios. So in this case, just like try to do all the cranial nerves. But this presentation, you have to like do everything in the optic nerve and everything in the facial. So you have to cover them in and out, right? Yeah, the optic and the H shape and yeah, oculomotor and all of them.
Okay.
Yeah, this part you need to like you didn't cover it in a good way actually. So the cranial nerve
Mm,
examination.
yes.
Yeah, so you didn't cover it. Yeah, so in the hand examination, you need to inspect the neck, then inspect the shoulders and these things as well. So it's part of the examination, and you have to do the rest of the hand examination. So you finish in you finish very early, so you still have time. So do the rest of the hand examination. So check the hand function, ask them to like grab a coin or grab coin, do the the grip. So ask them to grip your fingers. In that case, there'll be weakness in this gripping the affected side. So palpate the joints, palpate the joints individually. Check the pulse. So do all of the rest of the hand examination. You still have time. Okay. So you did, yeah. So you did the like reach the diagnosis, but you didn't even complete the examination. So it's important to complete the
Right.
examination as well. So you still have many tests to do in the examination. Okay. Um, yeah. So the chest tube I think was fine, was totally fine. But you like when you have been asked, even you are going to secure it, they want to see that skill, secure it, suture it. So don't wait, don't just so the exam is going to tell you talk through. I know it's not popular in Middle East centers, but it's very, very common in UK centers. So one of the commonest station in UK centers. Okay, and it's part of the curriculum of the MRCS Part B exam, so we have to know it. Okay, so yeah, so the same way. So we had it the same way. I just showed you. So the scenario, then the X-ray, and like you answered the definition and what you are going to do and these things. Just I'm going to go through the steps as like recommended. So there's going to be a mannequin. That mannequin having a hole on the side of the chest tube. That hole covered with silicone pad. You're going to do the incision on that silicone pad. So I'm going to confirm the site by chest examination, chest X-ray. I'm going to do stab incision, blunt dissection. So you're going to mention that, yeah. So I think you mentioned them, yes. Blunt dissection and finger sweep to ensure there's no lung tissue adherent to the chest wall. Then, yeah, preparing my equipment, including underwater seal. Then you are going to pick the small one. So if in case of pneumothorax, you are going to pick the small tube, yeah. So you don't need the large one. And then you are going to remove the trocar. So you're not going to use it with the trocar. And yes, we are going to use it with the, like, insert it with the artery forceps. So you're not going to hold it from the tip, just from the first hole with the artery forceps, and then direct it upward to the toward the opposite shoulder as you. Yeah, and then you're going to secure it with suture and dressing. So this is securing the suture and dressing, and remember the needle safety is very important. So after you take your stitch, you can just cut the needle because it's very important. One of the things, one of the professional marks is safety. So you can cut the needle and just throw it in the bin, secure the tube. So connect the underwater seal and then request X-ray. Okay. Yeah. So that patient was draped before cleaning the catheter patient. So you are going to clean first and then drape. So the patient was draped already. Yeah. So you're going to clean and then drape the patient, right? Expiry date of the gel. You didn't check the expiry date of the gel, so that important part of the professionalism, the safety. So it's very important. You check the expiry date of the catheter, but you forgot to check the expiry date of the gel. So make sure in the exam you have to insert the whole catheter. So before filling the or inflating the balloon, so the whole catheter has to be inside the urethra. Okay, so make sure the whole catheter inside the urethra, and you see the urine, and then after that you can inflate the balloon. But before that, you're not going to inflate it. If there's no urine, if the whole catheter is not inside the balloon, you're not going to inflate it. Okay. Yeah. So, any question, comment? So, other colleagues, any
Basically,
question?
this is very much helpful to get an idea before exam. The ways, because
Yeah.
one after another, when you do the station after station, so anatomy, pathology, and sometimes clinical examination history, means that gives a ideas. The mock exam which you are
Yeah.
taking, it's very much helpful. Otherwise,
Yeah.
while studying, we feel individual stations when we study, we feel it's very easy. But when we
Yeah.
try to attempt it one after other within 6 minutes, it's very difficult to remind everything. And the
Yeah.
short steps, what you are telling, just washing the hands, checking the expiry dates and suturing, and this nowhere it's not given. It's unless you do the practice and someone is watching it very carefully, then only it is possible.
Yeah. Yeah. And actually, in the last exam, even in knowledge station, there was hand sanitizer. Actually, in the last week exam,
In
even
knowledge.
all knowledge stations, even in knowledge stations. So very easy marks, guys. Very easy marks. Just by washing your hands, you are going to get mark. So most of the candidates are going to lose these marks. Actually. Yeah. Yeah. So yeah. Any question, comment, guys? Thank you again, Dr. Hamid. Thank you so much.
Thank you.
I
One more
think
thing I just
this
want
is
to.
going to be more stressful than the exam actually performing in front of the colleagues. Yeah.
No, no, no. Performing with the colleague, it's okay. Even if you feel something bad here, they can correct us. But
Yeah.
exam means you cannot means giving exam again next time. It's very horrible thing. If you want
Yeah.
to get out, because even
Yeah.
if the colleagues, everyone is doing the mistake. And what I am suggesting that you are taking it to very nicely. But if possible for you, I ask you to take a crash course before 15 days before the exam, 5 days crash course. So if you had any plan for that, because for example, my exam is on 28th of August. In
Mhm.
between of the August, if you keep a crash course of 5 days at least, so one day each part, and that will be helpful
So
for
yeah,
the
actually,
candidates.
okay, no problem, Dr. Hamid. I promise you to have a crash course 5 days before your exam. Yeah,
Okay, thank you very much.
you're welcome. Yeah, you're welcome. So, any question, guys? Any question, comment? So, guys, we can like, so anyone can have a question. They can open their mic and like ask their question, guys.
شكرا جزيلا دكتور حاد، جزاك الله خير.
وياك. Okay.
السلام عليكم.
عليكم السلام.
دكتور علي، بس أنا كان عندي question واحد عن إنه هل فعلا الستيشنز بتختلف في ايرلاند UK عن الميدل ايست سنترز عموما في الوطن العربي؟
No, actually, the curriculum is the same, but one of the stations, this one of the stations, like I haven't heard about it in the records in the Middle East. They just read. I haven't heard about it in the Middle East, but it's one of the popular stations. But the rest of the station are the same, actually.
Actually, because I am in Dublin and I'm just wondering whether I'm taking the exam in Dublin here or just to travel and take it outside. Because I hear so much bad recommendation
actually,
about here Dublin Center.
the really high standard. Actually, the centers, the UK centers and Ireland centers, actually. So that's the answer. But if you're prepared well, we have like many colleagues who passed this exam, even in Edinburgh, even in London. So they did that. Yeah. So it can be done, but it's very high standard actually. So if it's possible for you and you have the time and to travel and you can afford the cost, it's better to take it outside the UK or Ireland. Actually, it's better. But don't worry, we have many colleagues actually, and yeah. So we have many colleagues who passed cleared the exam in the UK actually, and I know them personally. If you want to talk to them, like just text me and like connect you with them.
Okay, thank you so much.
Yeah, welcome.
دكتور علي، استفسار بسيط بس عن الفاليديتي بتاعت الامتحان بتاع MRCS. انا كم سنه اتعاملت قبل فتره،
Yeah,
تقريبا 7 سنوات. مش كده؟
for part A. Yeah.
طيب حاليا لسه بالنسبه للبريبريشن او البراكتس اللي تعمل قبل شويه ده بخصوص السكيلز، ولا بالنسبه لباقي السكشنات
Oh,
الثانيه
no,
حتكون كيف بنفس الطريقه دي ولا في اختلافات؟
we did one of the knowledge stations at the beginning actually. So yeah, we did one of
ايوه.
the knowledge stations. Yeah, we gave example of knowledge as well.
اها. بالنسبه للباثولوجي والاناتومي بتكون بنفس الطريقه، مش كده؟
Yeah. Yeah, so they're going to be question and answer. The anatomy you are going to like most likely they're going to be like 4 or 5 pictures labeled like labeled each one like has 3 4 labels. Okay, they're going to ask you to identify the labels. So that's one of the things, and they're going to ask you questions as well. So in the anatomy, there's going to be pictures or like tablets or just pictures like on the wall or tablet. So you're going to have 4 or 5 pictures naming the structures and answering the labels. And then you're going to have questions about, for example, the incision of submandibular gland incision actually. So where the incision is going to be, which like nerve at risk of injury in this surgery. So it's going to be like that questions. Okay. For the pathology, they're going to give you a scenario, but the scenario is going to be clear. So this is the gastric cancer, for example, and you're going to go inside the station You're going to answer the questions. So types of gastric cancer, mode of metastasis, genes. They're going to give you histopathology reports and asking you questions regarding that report. In some stations, even the curriculum, even they're going to have like slides, histopathological slides, but it's not common in this, like not that common, but sometimes like samuma body in the thyroid, like they have like a slide for that. They're going to ask you to identify that histopathological picture. It's not common, but histopathological reports in the pathology are common. Then you're going to answer questions in treatment, in stages, in grading the cancers, and like these questions in the pathology. Okay.
كيف
And
كيف
actually, yeah, let me خليني أوريك Dr. Ahmed. We have Dr. Ahmed
اوكي
Abdelgadir is going to take some knowledge stations with us in the group as well. And I think he's with us here, so he's going to help with the knowledge part as well. Okay. Yeah.
ايوه
Yeah. So in the critical care, they're going to give you a scenario of trauma, for example, and you're going to be asked questions regarding that scenario. They're going to give you like imaging. They're going to give you results to interpret them. Blood gas, arterial blood gases, for example, renal profile, liver profile. So you're going to like given patient chart, fluid chart, drug charts, and these things. You're going to be given them, and you're going to interpret them. So this is the knowledge part. Okay.
اها اوكي
Okay. So
بالنسبه
any
للاشتراك
question? Again?
بالنسبه للاشتراك كيف؟
So for the small group course, you can text me in the WhatsApp. So just text me in the WhatsApp or Telegram. So this one for the main group or free group as well. So if you're asking about the small group course, you can text me.
We've got
Okay,
its
so any
courses and
question,
it's
guys?
it's very much. Thank you very much.
You're welcome. Any question, comment? Okay, so I think there's no question. So I will arrange with you, Dr. Ahmed, for the knowledge session. So guys, and as we used to do, we are going to announce in the group, telling you to book your session, and then we are going to practice. Okay. And Dr. Ahmed is going to help with the knowledge part. Thank you so much, Dr. Hamid, again. And thank you, guys. I'll see you next time. Thank
Okay.
you. Bye bye.
Dr. Ali,
Thank
yes.
you.
Yes, Dr. Ahmed.
Yes. Good evening, Dr. Ali, and our colleague. Yes, I am happy. It was brought to be with you. Inshallah, as you said, we'll start the knowledge part.
Yeah.
With just with your way. Yes, we'll start a session part for knowledge, just to simulate the exam.
Yeah.
We'll give 9 minutes for the candidate, 1 minute to read the scenario,
Yeah.
9 minutes for the question and answer, and then lastly comment.
Yeah.
Our
All
preparation
right.
will
Yeah.
start the next week, inshallah.
Inshallah. Thank you so much.
Thank you.
Yeah, thank you so much. So we'll announce in the group later on. Yeah, when we arrange it, inshallah. Okay. So thank you, guys. Thank you so much. I'll see you next time. Bye.